Hi, everyone. It is my pleasure to be here on behalf of a large group of people that have worked on these projects to talk to you about sarcopenia and malnutrition in autoimmune liver diseases. I have no disclosures. We know that malnutrition, unfortunately, is a common comorbidity of patients with liver diseases. And when we think about malnutrition in this context, we think about it predominantly in patients with chronic cholestatic liver diseases or in the context of end stage liver disease. And the reason why patients deal with malnutrition in these conditions is either because inflammation leads to malnutrition, or because these conditions contribute to maldigestion or malabsorption, and that ultimately affects their nutritional status. Over time, medication side effects may play a role. Patients may not feel good, so their physical activity decreases, and that plays additional roles in the development and progression of malnutrition. More recently, there's been a shift away from thinking of nutritional status as changes in weight and height and thinking more about changes in body composition. And we hear more and more this term of sarcopenia, which has to do with loss of muscle mass and function. So, sarcopenia has been seen in up to 70% of those with cirrhosis. And it's interesting and important because it has been linked to morbidity, mortality, and quality of life. In terms of patients with autoimmune liver diseases, we know they are at increased nutritional risk because they are dealing with maldigestion and malabsorption, depending on what condition they have. They certainly are dealing with inflammation, and at times they may have decreased activity, depending on the severity and stage of their illness. And they're exposed or may be exposed to medications such as corticosteroids, which we know have a direct impact on body composition. However, even though we know this, when we think about malnutrition in the context of liver diseases, we really don't think of patients with autoimmune liver diseases, again, unless we talk about end-stage liver disease. And that is also evident in the literature. There's actually very few data regarding body composition of these patients. In fact, there is a study, a single study in children where bioelectrical impedance was used in a small cohort of 34 patients with a mean age of 14 years. The majority of them were female, and they were about a year and a half following their diagnosis. All of them had autoimmune hepatitis, and 60% of them were on steroids at the time of assessment. And what this study showed with the use of BIA, bioelectrical impedance, was that 42% of these patients had excess body fat. So while this finding was important, it wasn't a result that would make clinicians rush into doing frequent nutritional evaluations. So given the paucity of the data in the literature, we at Cincinnati Children's decided to do some more work to determine and describe the body composition of patients with autoimmune liver diseases, and determine whether it correlates with clinical markers and quality of life. And we hypothesized that sarcopenia is in fact prevalent in patients with autoimmune liver diseases, and that it is linked to quality of life measures. This is a sub-study of another larger prospective cohort study that is investigating MRI biomarkers of chronic liver diseases. So in this study, we included anybody who was younger than 25 years of age and who had had an MRI between the years 2017 and 2020. We excluded those who had been imaged for conditions other than autoimmune liver diseases, and those who had insufficient MRI data for us to be able to assess their body composition. So we collected demographic, clinical, and laboratory data, and then we used their MRI information to obtain their body composition. And so how can one do that? This is an example of a very simplified example of what an MRI image can look like. And assuming that this is a patient laying on their back with their feet towards you and the head towards the back, this is the skin up top here. So you can segment the image that you get for the MRI and measure the subcutaneous fat, which is the distance from the skin to the interior wall of the anterior abdominal muscles, or the six-pack. And then you can measure the visceral fat, which is the fat behind that and up to the anterior aspect of the vertebrae. And then in terms of muscle mass, what we did is we measured the surface area of the psoas muscles. And we did that because there is previous literature doing that in adults, and because this can be done in children as well. And there's data on that in children. And there's particularly important norms in children. So we calculated the total PMSA, psoas muscle surface area, or TPMSA, which is the sum essentially of the right and left. And as I mentioned, we compared it against norms, which you can see here. This is an example of an online calculator that allows you to get a TPMSA z-score and a percentile. So the same way that we get a weight, height, and BMI z-score, you can get that for TPMSA measurement by plugging in the patient's age, their sex, and the lumbar level at which the measurement was obtained, as well as the TPMSA measurement. And we define sarcopenia as a TPMSA less than the fifth centile. And you see here, a less than the fifth centile would represent a measurement below the fifth line, which in other words means that this measurement would be below 95% of the measurements of other kids, same sex, same age. We also collected quality of life information using PedsQL, which assessed physical functioning, emotional, social, and school functioning, as well as general well-being and general health. This was completed by both patients and parents, and the parents were providing our perspective, their point of view as far as their children's health was concerned. So here are our results. We included 58 patients in this study. 43% female, the majority were white, and 57% had autoimmune hepatitis. Here are the baseline characteristics of the entire study cohort. The first column has the cohort all together, and the other two columns have the patients separated into AIH and ASC-PSC groups. The baseline characteristics are, as you would expect, the age at MRI is about 16 years in the patients. The majority of the patients were a little over a year following their diagnosis. Again, we would expect the majority of the patients with ASC-PSC had an IBD diagnosis, which again might have an impact on their nutritional status, but few of patients with AIH had IBD. And then in terms of steroid exposure, which has an impact on body composition as well, at the time of MRI, about half of patients were exposed to steroids, but when looking at more long-term exposure, more than 3 months, more than half of the patients had had that exposure. Importantly, looking at their BMIs, none of their BMIs or BMI z-scores were very concerning. And in fact, if we were to use the BMI to define malnutrition, even mild malnutrition was seen in only 2 of those patients, or 3% of the cohort. So this is similar to what we see in clinical practice, which is why these patients in general are not considered at nutritional risk. These are the labs of the patients, and the labs are as we would expect for patients with these conditions. Here, I just want to highlight from an albumin and an INR perspective that the patients did not have significant drops in their albumin or significant elevations in the INR, suggesting that the majority of these patients did not have end-stage liver disease. These are the results of their body composition, and these numbers probably don't mean anything to anyone. The point here is to show that there were no significant differences between patients with autoimmune hepatitis versus ASC-PSC. This figure, I think, represents the first key finding of this study, which is the fact that if we were to show the distribution of TPMSA of all the patients with autoimmune hepatitis, ASC, and PSC, and use that threshold of the 5th percentile to define sarcopenia, we see that a significant proportion of patients actually have sarcopenia. Of these patients who, from a BMI perspective, would actually not be considered at risk. So the PSC cohort, more than half of the patients are below the threshold. ASC, the same. Autoimmune hepatitis, about a quarter of these patients are below this threshold. So this was a very concerning and surprising finding. When we divided the patients into sarcopenic and non-sarcopenic, what we found was that there were no significant differences in terms of age, duration of disease, diagnosis, presence of IBD. One thing that was different in terms of their laboratory investigations was that the BUN was lower in those who were sarcopenic, and that is to be expected as BUN has to do with muscle mass, but their creatinine was not. And then looking at their other measures of body composition, the visceral fat area was significantly higher in those who were sarcopenic, and this was another surprising finding. In terms of the effect of steroids, we didn't see any significant differences in the body composition measurements between those who were receiving steroids and those who were not receiving steroids. So we put this information into multivariable modeling to see which factors actually predicted sarcopenia. And after including age, BMI, duration of disease, steroid use, and the diagnosis into the model, the only variable that predicted sarcopenia was actually the visceral fat. We then proceeded with the quality of life measurements, and we saw that indeed there were some differences between those who did and did not have sarcopenia, with higher scores in parent-reported general health seen in those who did not have sarcopenia. And in the multivariable modeling, the patient-reported quality of life and general health was found to be negatively associated with visceral fat, whereas the parent-reported general health score negatively correlated with sarcopenia. So we then decided to see, is this something specific to autoimmune liver diseases, or is this something that has to do with pediatric liver diseases in general? So we compared these findings against another cohort of patients, a cohort of patients with non-alcoholic fatty liver disease. So you see here this cohort at 53 patients, and of course the patients were quite different in the sense that their BMI Z-score was much higher, and they were a little bit younger. The distribution in terms of sex and race was just a little bit different. And you see here that the prevalence of sarcopenia was much lower at 9% in this cohort. And actually, with propensity score matching, we found that even after including and matching for variables such as age, sex, race, and BMI Z-score, the odds ratio for sarcopenia was 14.5 in those who had autoimmune liver diseases versus NAFLD. So in summary, sarcopenia is highly prevalent in patients with autoimmune liver diseases. It is not readily detectable with traditionally used tools, such as BMI. It is associated with increased visceral fat, and both sarcopenia and visceral fat are linked to lower quality of life scores. So in terms of future directions, it's important to understand the pathophysiology and see, is it the chicken or the egg? What causes what? And also, it is important to study the reversal of sarcopenia prospectively, and perhaps this can happen within this network, and see, can we reverse the sarcopenia, and how do we do this with nutrition alone, nutritional physical therapy, changes in medications, and if we are able to reverse it, does that improve outcomes? And just in 1 minute, I will show you an exploration into the pathophysiology, where we, in a cohort of patients with autoimmune hepatitis, a small cohort, we had plasma samples that were subjected to SomaScan analyses, where essentially quantifying a large number of proteins to just explore associations that are hypothesis generating, essentially. In this sub-cohort, 53 patients with AIH were found to be sarcopenic. And what we found was that there were multiple proteins that were downregulated, and among those were proteins such as STAT3, that is important for the regulation of satellite cells in skeletal muscle that are important for muscle recovery, as well as other proteins that are important for mitochondrial oxidative stress response that may have to do with the energy at the level of the cell. And there was an upregulation of other proteins that have to do with inflammation, which we then know inflammation is linked to sarcopenia through different mechanisms. And also proteins such as FAPP3, which has previously been linked to cancer cachexia. So I'm going to leave you with this. And I would like to acknowledge all the people that have done a lot of this work that I am just presenting today. Members of the gastroenterology department. I would like to acknowledge work done by Dr. Amivar, who was a nutrition fellow with our program and is now an attending with us. Dr. Yadoshi was a research fellow. Dr. Panzaraji, who is still a fellow with us. Rishi Kani, who've done a tremendous amount of work on this. Dr. Taylor, Dr. Miethke, who gave us access to this population. Of course, our radiology colleagues without whom we couldn't do this, and our biostatisticians who, again, without whom we couldn't do this. So thank you very much, and I'm happy to take questions.
Good afternoon. I'd like to thank the organizers for allowing me to present our very recent and unpublished data on monogenetic causes for autoimmune liver disease in children. I have nothing to disclose. Let's start with a primer on DNA and genetic causes for disease. The DNA encodes the genetic information from our parents. Genes are segments of DNA with the blueprint for the sequence of amino acids forming specific proteins which control cellular function. Most cells contain 2 copies for most of the genes, one inherited from the mother, the other from the father. Changes in the DNA code for a gene can be disease-causing either through loss of function or through gain of function mutations of the encoded proteins in liver cells, bile duct cells, or immune cells. We believe that studies on the genetic underpinning of autoimmune liver disease will improve our ways to diagnose and classify AILD and help to identify novel targets for better therapies. The development of most diseases, including liver diseases, is a combination of genetic predisposition and environmental factors. The contribution of genetic factors varies depending on the disease. It is small in alcoholic liver disease and large in inherited liver diseases like PFIC. Autoimmune liver disease is traditionally considered a polygenic disorder, which means that common variants in many genes contribute to the genetic risk to develop the disease. Genome-wide association studies in adults with PSC or autoimmune hepatitis have helped to identify those risk factors. We hypothesize that in children, the genetic component is stronger than in adults and therefore leads to early onset of autoimmune liver disease. Such stronger genetic risk factors may result from rare and disease-causing variants in a few genes critical for the protection of the liver and bile ducts from autoimmune injury. In our study, we used whole exome sequencing on a research basis. In whole exome sequencing, we sequence in parallel the exons and intron exome boundaries of all 20,000 genes known to be translated into proteins. Our whole exome sequencing was performed at Perkin-Elmer at 100x sequencing depth, which is very high quality. The most difficult part of the project was left to Dr. Alex Valencia. Alex used to be a director at the Molecular Genetics Laboratory at CCHMC. Using several databases, Alex would filter out the genetic variants in each patient which might be important for autoimmune liver disease, annotate them in respect to the frequency of these variants in the general population, and collate published evidence for association with disease. We would then focus on rare variants which are found in less than 1% of the population, which affected the amino acid sequence of proteins and which were predicted to be damaging. Alex would designate whether the variant was found on both copies of the gene, called homozygous, or on one copy, called heterozygous. We would consider variants potentially disease-causing if we want 2 variants for genes associated with autosomal recessive disorder, or 1 variant associated with the disease inherited in autosomal dominant fashion. We enrolled 47 of our patients with autoimmune hepatitis N or PSC in this study. 5 of them had genetic variants identified by clinical testing. In 42 subjects, we used research whole exome or whole genome sequencing to find mutations. Biallelic mutations in genes associated with autosomal recessive disorders were found in 3 subjects. The genes were NBAS, which is associated with recurrent acute liver failure, DOG8, which is an immunodeficiency associated with hyper-IgE and recurrent food allergies, and an AIR, which causes autoimmune polyendocrinopathy syndrome. I will discuss the patient with mutations in an AIR a little bit later. We were surprised to find several patients with rare heterozygous variants in genes associated with autosomal dominant autoinflammatory disorders. 4 patients with variants in TNF-ALP3, 4 with variants in PLCG2, 2 with IFIH1, 2 with TREX1 mutation, and 1 with variants in NOD2, and another one with a variant in IFNGL1. We found rare variants in genes associated with immunodeficiency, in particular GATA2, which has been reported to be associated with autoimmune hepatitis before, and in genes associated with Kabuki syndrome. 6 patients harbored rare variants in genes regulating the complement pathway. 1 patient was diagnosed with a variant in Notch2 causing Alagille syndrome. Here are the building blocks of how we will determine which of the genetic variants are responsible for autoimmune liver disease. The basis of genetic studies is frequencies. The less common a variant is in the general population, the more likely it is that this variant affects the function of the encoded protein. More importantly, the more patients with PSC or autoimmune hepatitis we find to harbor rare variants in the same gene, the more confident we can be that this gene is important in the pathogenesis of autoimmune liver disease. The second level of evidence comes from laboratory studies, testing how the variants change protein function and how altered function of specific proteins relates to mechanisms of autoimmune liver disease. The ultimate proof of causality would come from clinical trials in which we target these genes or their encoded proteins with specific small molecules or biologic therapies and show that these treatments improve the liver disease in patients with PSC or autoimmune hepatitis. In A-LiNK, we try to model to some extent what has been done successfully in inflammatory bowel disease before. Here's another great success story we would love to repeat for autoimmune liver disease. In 2006, genome-wide association studies found variants in the IL-23 receptor to be associated with Crohn's disease. And just 10 years later, it was proven that monoclonal antibodies blocking a subunit of this receptor induced remission in patients with moderate to severe Crohn's disease. Let me illustrate the type of knowledge which can be gained from studies on genetic causes of liver disease. We recently saw a 14-year-old patient with a history of hypoparathyroidism, hypothyroidism, pancreatic exocrine deficiency, and candida esophagitis. She was referred to us because of elevation in her LFTs. Our workup showed elevated IgG levels, but negative autoimmune serology. A liver biopsy showed severe inflammation with prominent plasma cell infiltration, acute pericholangitis, and early fibrosis. We diagnosed her with autoimmune polyendocrinopathy syndrome-associated autoimmune hepatitis and started treatment with budesonide, azathioprine, and ursodiol. Her LFTs improved promptly. Clinical testing showed homozygous mutations in AIR. AIR is a fascinating gene which is indispensable for maintenance of central tolerance. It coordinates the deletion of self-reactive T cells in the thymus. If deficient, development of self-tolerance is disrupted, and clones of self-reactive T cells escape the deletion in the thymus and gradually damage endocrine organs and other tissues, including the liver. The NIH recently published a case series of patients with genetically proven autoimmune polyendocrinopathy syndrome 1. 42% of them developed autoimmune hepatitis. The mutation of our patient was frequently associated with autoimmune hepatitis. Important for our treatment decision was that in this case series, most of the patients responded well to conventional treatment of autoimmune hepatitis with corticosteroids and immune. This was surprising to me, and as I expected this type of autoimmune hepatitis to be more difficult to treat. I do believe it also shows the importance of establishing a genetic diagnosis early which will help anticipating the various complications and tailoring the therapies. Next, I would like to discuss a gene which we identified in several of our patients and which has not been linked to autoimmune hepatitis in children before. This gene, TNF-AIP3, encodes A20, a zinc finger protein, which is rapidly induced by TNF-alpha and inhibits NF-kappa B activation and TNF-alpha mediated apoptosis. Heterozygous deleterious mutations are associated with Behçet's disease, and it was also found in an infant with very early onset IBD. Patients with a haploinsufficiency in A20 were reported to have recurrent fevers, painful skin disease, as shown in the figures B and C, and digestive and genital ulcers. We have a case series of 4 patients in which we diagnosed haploinsufficiency for A20 associated autoimmune liver disease. Patient 1 presented as an infant with type 2 autoimmune hepatitis and acute liver failure. This patient was subsequently found to harbor a heterozygous duplication in TNF-AIP3, which led to a deletion of 1 copy. Her mother told me that there was a strong and unexplained family history of oral and genital ulcers on the mother's side of the family, including the mother, maternal grandmother, maternal uncle, and aunt. Our patient responded well to treatment with prednisone and Celstat. Our second patient presented at age 10 with seronegative autoimmune hepatitis and Hashimoto thyroiditis. Cases 3 to 6 belong to one family in which mother and 3 children carried the same deletion of the entire coding sequence of 1 copy of TNF-AIP3. While 2 siblings presented with autoimmune hepatitis, our cases 3 and 4, the third child with the mutation has not developed liver disease. All patients in our case series presented with type 2 autoimmune hepatitis based on either positive serology for LKM or LC1, or they were seronegative. Here we put together representative photomicrographs of the liver pathology at diagnosis. Panlobular inflammation consistent with presentation in acute liver failure was found in case 1 on the very left, whereas more typical features of autoimmune hepatitis with interface hepatitis and follicle formation were found in the other 3 patients. Please note the extensive fibrosis at diagnosis in patient 3 at the left lower corner. In summary, we identified TNF-AIP3 as a novel genetic susceptibility factor for familial seronegative or type 2 autoimmune hepatitis. As you may remember from the first overview, we found heterozygous variants and several genes associated with autoinflammation in IFIH1, PLCG2, and TREX1. These genes are associated with interferonopathies, which are conditions causing periodic fevers, skin disease, and rheumatologic complications. The NIH has discovered that many of affected patients display upregulation of 28 genes in the peripheral blood, which are associated with the interferon pathways. Importantly, this panel allows rheumatologists to tailor their biologic therapies to individual patients classified by genetic diagnosis and expression levels of interferon-associated genes. In order to examine whether genetic variants in these genes were associated with upregulation of interferon-associated genes in patients with autoimmune liver disease, Esther Malik from our lab isolated the RNA from PAX-RNA gene tubes for Techman-based qPCR, and Rebecca Carnes performed unsupervised analysis of the gene expression pattern. In this heat map here on the left, you can see the various genes listed at the bottom, and the rows represent individual patients. Patients denoted in green are healthy controls, and in purple, these are our patients, particularly those who we found to harbor deleterious mutation in at least 1 copy of genes encoding for autoinflammatory conditions. Yellow color of the boxes denotes high expression, blue stands for low expression of the gene in blood mononuclear cells. Most of the healthy controls show only little expression of the genes. Here at the top, our patients with a mutation in the NOD2, which is associated with inflammatory bowel disease, shows the highest activation of almost all of the interferon genes in peripheral blood. Patients with rare variants in PRCG2 and those with variants in IFIH1 segregate together, indicating that these genetic variants may polarize the interferon signature in a specific way. In summary, our survey for monogenetic causes for autoimmune liver disease in children with autoimmune hepatitis N or PSC has provided the following results. Biallelic mutation in genes potentially associated with hepatitis occurred in 3 out of 47 patients. Heterozygous variants associated with disease inherited in autosomal dominant fashion were detected in 27 out of 47 subjects, 57%. We have strong evidence that for a pathogenic role in autoimmune liver disease for the following genes: AIR, GATA2, and TNF-ARP3. There is early evidence that rare variants in genes causing autoinflammatory conditions polarize interferon response and may predispose to the development of autoimmune liver disease. What are the next steps in Cincinnati? Whole exome sequencing of 16 additional samples is currently underway. Asta and Annika, in collaboration with Dr. Ken Iwasawa and Taka Takebe from the Center for Stem Cell and Organoid Medicine in Cincinnati, are currently developing liver organoid models from patients with variants in TNF-ARP3, IFIH1, PRCG2, and NOD2. Junye Yin from our GI division has developed zebrafish models for TNF-ARP3 and IFIH1 deficiency. I would like to close my presentation with an outlook into something I envision for the not too distant future. I hope that the Cincinnati studies may provide the basis to perform genetic screening across A-LiNK sites. One design of such a study could be to approach patients included into the retrospective study, which Dr. Wyman has discussed earlier. And if patients' family consented to the study, we would obtain blood for genetic testing and gene expression profiles. We would perform similar studies as I had just described in a much larger and heterogeneous group of well-characterized patients. Importantly, we would not only study which gene changes are associated with certain types of autoimmune liver disease, but we would also investigate whether returning of the results to the sites makes an impact on care, which of the genetic findings are confirmed by clinical testing, and how knowledge of genetic diagnosis affects well-being of the families. Whether a genetic diagnosis ultimately changes treatment and outcomes of autoimmune liver disease will be captured in our prospective A-LiNK study. We are curious to hear the family voices on the design of such a study. We hope that this is a study to attract Euro 1 level funding from the NIH to A-LiNK. None of these studies would be possible without our amazingly supportive patients and families. I would like to thank again all the scientists who contributed to this project and to our supporters for their donations to CULT, which funded this project. And now I'm open to questions.